Muy buenos días. Les damos la bienvenida a la Pontificia Universidad Javeriana y a este segundo Congreso de Navegación de Pacientes en Latinoamérica. Para nosotros es un gusto que estén acompañándonos de manera presencial y también saludamos de manera especial a las personas que se encuentran en este momento conectados a través de conexión streaming. El objetivo del Congreso es difundir las experiencias de navegación de pacientes desde una perspectiva integral. A continuación invitamos a nuestra mesa directiva, la doctora Esperanza Peña Torres, el doctor Adib que nos acompaña desde su conexión virtual, el doctor Freeman que también nos acompaña desde conexión virtual, y a la licenciada Nancy Peña que nos acompañen por favor en la mesa para dar inicio a la presentación de la agenda. A continuación me permito presentarles el programa que vamos a seguir y que hemos preparado para ustedes en este evento. Primero tendremos el himno nacional de la República de Colombia. Segundo, la apertura e instalación del evento. Tercero, daremos inicio a las actividades académicas. Les solicito ponernos de pie para escuchar el himno nacional. Muchas gracias. Pueden tomar asiento. Para la instalación del evento invitamos a la doctora Esperanza Peña, decana de la Facultad de Enfermería de la Pontificia Universidad Javeriana.
Muchas gracias, Carmen Lucía. Buenos días para todos. De verdad, estoy absolutamente feliz de estar acá dando inicio a este evento. Estoy muy feliz. Y además de eso, es un honor estar dando inicio a este congreso sobre un tema tan relevante. Una estrategia que a través de los años ha demostrado tener un impacto directo y positivo en la vida de muchas personas alrededor del mundo. En primer lugar, quiero destacar la historia que dio origen, y sé que la vamos a oír varias veces hoy, a este concepto tan innovador. Los navegadores de pacientes surgieron en la década del 90 en Estados Unidos, en Harlem, Nueva York. Y el objetivo era superar las barreras que enfrentaban pacientes, especialmente mujeres afroamericanas que tenían un diagnóstico tardío de cáncer de mama. Este objetivo de superar las barreras es un concepto que con el tiempo tomó fuerza, no solo en los Estados Unidos, también en otros países, muchos de ellos miembros de la OCDE, y han logrado un impacto positivo en diversas áreas de atención en salud, desde el cáncer hasta la atención de personas en condiciones de alta vulnerabilidad, también en personas que no son tan vulnerables. Estamos hablando con Nancy. Hoy, como es evidente, en Latinoamérica, en Colombia, en Guatemala, hoy específicamente en Bogotá, también tiene asidero esta estrategia. Para nosotros en la Universidad Javeriana, especialmente en la formación de estudiantes de maestría en enfermería oncológica, en alianza con la organización NPI, con quien llevamos trabajando ya 3 años, y con la Universidad del Istmo en Guatemala. Uno de los primeros y más destacados campos de la implementación de los navegadores de pacientes ha sido la atención en cáncer, como les estaba diciendo. Todos aquí sabemos que garantizar que los pacientes reciban atención de alta calidad y oportuna es algo que es una condición que enfrenta grandes desafíos. Entre ellos, uno de ellos son las barreras de acceso, pero también la coordinación entre proveedores y entornos de atención y, lo que es más grave, en las inequidades en salud que existen en muchos países, específicamente en países latinoamericanos. Un claro ejemplo de éxito de este programa es el Patient Care Connect en los Estados Unidos, implementado por la Universidad de Alabama. Un programa que utiliza orientadores de pacientes capacitados, no necesariamente profesionales de la salud, pero que están autorizados para acompañar a los pacientes en todo su recorrido, desde el diagnóstico hasta la supervivencia e incluso la atención al final de la vida. Este modelo al que me refiero abarca 12 centros oncológicos en varios estados y ha demostrado cómo la introducción de navegadores de pacientes reduce las inequidades en el acceso a la atención, mejora la calidad de vida de los pacientes, especialmente en zonas rurales y urbanas marginales. Otro campo de los navegadores de pacientes está demostrando su valor es en el cuidado de la transición. Sabemos que los pacientes que pasan de un entorno hospitalario a su hogar o de la atención hospitalaria a los servicios sociales enfrentan una serie de dificultades que pueden llevar a reingresos hospitalarios o complicaciones en su salud. Los navegadores, especialmente los que trabajan con personas mayores con enfermedades crónicas, desempeñan un papel realmente crucial y relevante. En estos casos, los navegadores ayudan en la planificación de la atención durante el alta, coordinando las visitas domiciliarias y ofreciendo apoyo telefónico para garantizar que el paciente no solo reciba los servicios necesarios, sino que también puedan navegar con éxito por los sistemas sociales y de salud. Este modelo ha demostrado ser eficaz en la mejora de la calidad de la atención y en la reducción de reingresos hospitalarios, lo cual obviamente impacta la sostenibilidad de los sistemas de salud. Otro de los desafíos más complejos que enfrentamos es el acceso de pacientes vulnerables a los servicios de salud. Las personas en condiciones de alta vulnerabilidad, como las minorías étnicas, los inmigrantes, las personas sin hogar o los individuos sin aseguramiento en salud, suelen enfrentar barreras significativas en su acceso a la atención, lo que lleva a un diagnóstico tardío y en consecuencia a peores desenlaces en salud. Los navegadores de pacientes juegan un papel clave al servir como puente entre estas comunidades vulnerables y los sistemas sociales y de salud, ya sea a través de la divulgación comunitaria, visitas domiciliarias o la organización de llamadas telefónicas. Los navegadores ayudan a identificar las barreras que enfrentan las personas, que puede ser incluso una barrera en el idioma, hasta factores financieros, y les proporcionan el apoyo necesario para acceder a la atención y realizar las pruebas de detección o de rehabilitación en su enfermedad. Un claro ejemplo de esto es el programa de navegación de pacientes en otro país como Alemania, en Stuttgart, que trabaja con comunidades inmigrantes para educarlas y facilitar el acceso a los servicios. Este modelo demuestra cómo los navegadores, especialmente los que provienen de las propias comunidades que ellos apoyan, pueden hacer una diferencia significativa en la vida de los pacientes más necesitados. Sin duda, una estrategia innovadora. He hecho varios resúmenes de evidencia al respecto, pero traje estos 2 ejemplos exitosos y que han mostrado tener una expansión a nivel global. Otros países en Europa han comenzado a implementar iniciativas similares, aunque con diferentes niveles de ejecución y alcance. Las lecciones que hemos aprendido de estas experiencias internacionales son invaluables y nos brindan la oportunidad de ajustar y mejorar nuestros propios modelos. A eso le estamos apuntando con estas estrategias. El aumento de enfermedades crónicas y la complejidad creciente de la atención a los pacientes hace que los navegadores sean más necesarios, hoy más necesarios que nunca. Los sistemas de salud deben adaptarse a un mundo en el que los pacientes requieren atención multidisciplinaria, social, comunitaria, y los navegadores son ese eslabón que permite la integración de los servicios. Es esencial que a medida que avancemos, nos enfoquemos en la sostenibilidad de los programas de navegación de pacientes. El éxito de estas iniciativas no solo depende de la capacitación adecuada de los navegadores, también de la colaboración entre todos los involucrados, profesionales de salud, organizaciones comunitarias, tomadores de decisiones y, por supuesto, los propios pacientes. En este sentido, organizaciones como la American Cancer Society han sido clave en el desarrollo de modelos de navegación que buscan abordar las disparidades en el acceso al cáncer. La American Cancer Society ha promovido la importancia de la evaluación de los modelos existentes, buscando aquellos que sean sostenibles y que ofrezcan el mayor retorno de la inversión, no solo en términos financieros, también en términos de equidad y acceso a la salud. Para concluir, es un honor para nosotros en la Pontificia Universidad Javeriana haber elaborado en compañía de NPI y la Universidad de Licda en Guatemala un evento tan significativo, yo creo que de magnitud histórica, y creo no estar exagerando, el cual hasta el día de hoy no había sido desarrollado de manera presencial en Latinoamérica. Este congreso no solo representa un avance significativo en la atención y navegación de pacientes oncológicos, sino que también subraya el compromiso de la Facultad de Enfermería de la Pontificia Universidad Javeriana con la formación de profesionales altamente capacitados, capaces de liderar el cambio en el campo de la enfermería oncológica. La Universidad Javeriana ha sido pionera en Colombia en el campo de la enfermería oncológica. De nuestra institución trabajamos cada día para fortalecer la enfermería oncológica como una disciplina clave en la atención integral de los pacientes, no solo en Bogotá, en todo el país. Pero en un territorio como Bogotá, con su diversidad y complejidad, nos hemos comprometido a ofrecer una educación inclusiva y de calidad, formando enfermeros que sean agentes de cambios y defensores del bienestar de nuestros pacientes. Me gustaría resaltar la importancia de la alianza con la Secretaría Distrital de Salud, un trabajo conjunto que refuerza nuestro impacto y nos permite llevar a cabo una labor social fundamental para garantizar que cada persona, independientemente de su contexto, reciba el mejor cuidado posible. En nombre de la Facultad de Enfermería, agradezco profundamente a todos la participación en este congreso, el cual sin duda marcará un hito en la navegación de pacientes en toda la región. Que este encuentro sea el inicio de nuevas colaboraciones y avances en la salud oncológica, donde la capacitación, la inclusión y el compromiso social están enfrente de nuestro trabajo. La navegación de pacientes representa una de las innovaciones más prometedoras en la atención en salud, desde el cáncer hasta la atención de personas en condiciones de vulnerabilidad, la gestión de las transiciones. Sin embargo, a pesar de todos estos esfuerzos, aún debemos continuar evaluando y perfeccionando los modelos para garantizar su sostenibilidad y su capacidad de adaptación a los cambios constantes en el sistema de salud y en las contingencias que hoy en día enfrenta nuestro país. Hoy, en este congreso, tenemos la oportunidad de compartir experiencias, aprender unos de otros y construir el futuro de la navegación de pacientes. Estoy segura de que este será un espacio productivo, lleno de ideas valiosas para continuar avanzando en este importante cambio. Muchísimas gracias y bienvenidos.
Muchas gracias, Esperanza. Invitamos al doctor Adib Rodríguez, decano de la Facultad de Ciencias de Salud de la Universidad del Istmo de Guatemala. Él nos acompaña de manera remota. Adelante, doctor Rodríguez.
Muy buenos días. Estimada decana de la Facultad de Enfermería de la Pontificia Universidad Javeriana, Magíster Esperanza Peña Torres, licenciada Nancy Peña, directora y fundadora de NPI, todos los asistentes a este congreso, muy buenos días. Verdaderamente es un honor para mí dirigirme a ustedes, especialmente para aquellos que día a día asumen con compromiso, pero sobre todo con muchísima sensibilidad, la tarea de cuidar a personas que enfrentan diagnósticos como el cáncer y otras enfermedades crónicas. El propósito de esta reflexión es compartir una mirada académica y regional sobre la navegación del paciente, un modelo, como ya mencionó Esperanza, que ha demostrado mejorar la continuidad del cuidado, la experiencia del paciente y los resultados en salud. En nuestra región latinoamericana, este enfoque se ha adaptado a las realidades sociales, económicas y culturales, convirtiéndose en una herramienta estratégica y humana para fortalecer los sistemas de salud. De acuerdo con la American Cancer Society y el National Cancer Institute, la navegación del paciente se define como un proceso individualizado de guía, educación y acompañamiento que ayuda a las personas a superar barreras en el sistema de salud, desde el diagnóstico hasta la resolución del tratamiento. En la práctica, el profesional navegante, que frecuentemente es una enfermera, enfermero o trabajadora social con una formación específica, actúa como coordinador del cuidado, facilitador de la comunicación interdisciplinaria y defensor del paciente, asegurando que las decisiones clínicas se traduzcan en acciones efectivas y oportunas. Diversos estudios internacionales han demostrado que los programas de navegación reducen los tiempos de diagnóstico y tratamiento, especialmente en cáncer de mama, cuello uterino y colon. Incrementan la adherencia terapéutica y el seguimiento de los pacientes en tratamientos prolongados. Mejoran la satisfacción del paciente y la calidad percibida de su cuidado. Fortalecen la comunicación entre los niveles de atención y disminuyen la fragmentación del sistema. En América Latina, aunque la evidencia científica aún es emergente, se han publicado experiencias en México, Colombia, Brasil, Chile, Argentina y otros que reportan beneficios similares, adaptando los modelos a los recursos locales y a las necesidades de la población. Colombia, por ejemplo, los programas de navegación en cáncer de mama han reducido significativamente la pérdida de seguimiento entre el diagnóstico y el inicio del tratamiento. En Brasil, la navegación ha sido incorporada en políticas regionales de salud como parte del fortalecimiento de la red oncológica. Las enfermeras y enfermeros poseen un papel protagónico en la implementación y sostenibilidad de los programas de navegación. Desde el enfoque del cuidado integral, su participación permite integrar dimensiones clínicas, psicosociales, educativas y comunitarias en la experiencia del paciente. Entre las competencias clave que la literatura destaca para el rol de la enfermera o enfermero navegador está la comunicación terapéutica avanzada y habilidades de consejería, gestión de casos y coordinación interinstitucional, educación del paciente y la familia para la toma de decisiones informadas, evaluación de barreras de acceso y diseño de planes de cuidado personalizado. De esta manera, en el grupo de enfermeras y enfermeros se consolida como una disciplina estratégica para la humanización del cuidado y la equidad del acceso a los servicios de salud. Sin embargo, la implementación de estos programas de navegación en nuestra región enfrenta desafíos importantes. Limitaciones estructurales en los sistemas de salud, caracterizados por la fragmentación de servicios y la desigualdad en la distribución de recursos. Falta de reconocimiento formal del rol del navegante, tanto en el marco normativo como en los perfiles ocupacionales. Insuficiente formación académica en competencias específicas de navegación, comunicación y coordinación del cuidado. Escasa producción científica local que documente y evalúe resultados con metodologías rigurosas. No obstante, estos retos deben ser vistos como oportunidades. Instituciones académicas, hospitales y asociaciones profesionales están en posición de liderar procesos de investigación, formación y cooperación regional que permitan consolidar modelos propios de navegación, culturalmente pertinentes y, como se mencionó, sostenibles. Una de las principales fortalezas de América Latina es la capacidad de aprender y de adaptarnos. Por eso es fundamental documentar y compartir nuestras experiencias, como se hará en este Congreso. Construir repositorios, redes y espacios de intercambio académico que visibilicen las iniciativas locales y fomenten la investigación colaborativa. Los congresos, seminarios y publicaciones científicas regionales deben servir como plataforma para difundir las lecciones aprendidas y los resultados del impacto. Solo así podremos fortalecer una red latinoamericana de navegación del paciente, sustentada en la evidencia, la ética del cuidado y el compromiso social. La navegación del paciente representa una evolución en el paradigma del cuidado, un modelo centrado en la enfermedad a uno centrado en la persona y su trayectoria dentro del sistema de salud. Insisto, centrado en la persona. En contextos donde las enfermedades oncológicas y crónicas representan un desafío creciente para la sostenibilidad de los sistemas, la integración de los sistemas y los programas de navegación liderados por los servicios de enfermería deben de ser una prioridad y una necesidad impostergable. Invito a cada uno de ustedes, futuros y actuales profesionales de la salud, a formarse, investigar y compartir sus experiencias, porque el conocimiento compartido es el camino para la transformación. Cuando un profesional acompaña con ciencia y compasión, cuando una enfermera o enfermero orienta con conocimiento, con humanidad, el sistema de salud se vuelve más justo, más eficiente y muchísimo más humano. Muchas gracias, muchos éxitos en este congreso y muy agradecido por la invitación a participar.
Muchas gracias, doctor Rodríguez. Bueno, y nos acompaña nada más y nada menos que el doctor Freeman, padre y pionero del modelo de navegación de pacientes. Él está conectado desde Estados Unidos en este momento. Vamos a iniciar con un video que él ha grabado para nosotros y posteriormente, para no cortar aquí la comunicación, nos acompañará la licenciada Nancy Peña, quien es directora y fundadora de Navegación de Pacientes Internacional NPI. Doctor Freeman, bienvenido a este gran encuentro.
Good morning. I'm Dr. Harold Freeman. I'm very happy to be with you today at the second Patient Navigation Congress in Latin America. And I have prepared a talk today to tell you how navigation developed in the community of Harlem and how it extended to the whole country and ultimately to the world. The challenge of navigating people through a complex healthcare system. And this is what I'm going to talk to you today about. The way I see it is through this patient navigation model that you see in front of you. Surely on the outreach side, we have to reach out to help to tell people to come into the system for a particular test. That is called outreach. The problem is when people come in who have an abnormal finding, what can we do to help them to get through the complex system to diagnosis and treatment? And so the early concept of patient navigation started at the point of an abnormal finding, such as a lump in the breast. A poor person coming to the Harlem emergency room with a lump in the breast, who had to wait a long time to see a doctor first, and then was told that they did not have insurance and they had to go to find coverage before they came back to the hospital. So the patient navigation model was really based on the challenges that people who were poor in Harlem had to meet to get through a system, the elimination of the barriers to get them to resolution. And that was the patient navigation model in its beginning back in 1990. So with that beginning, the question is, so what is the current system in America that's called patient navigation? Well, it's come a very long ways. From 1990 to now, the current situation is that patient navigation is a part of the healthcare system in America. And how did that happen? It happened because we were able to show the Congress of America, for example, that this was what had to be done to save lives. So by the year 2005, the President of the United States, who was George Bush, signed what was called the Patient Navigation Act based on what had happened in Harlem. And the Patient Navigation Act gave funding to assist people through the journey through the healthcare system. And the current situation in America is that patient navigation is now covered under Medicare, which is the system of payment for healthcare for people, particularly who don't have money. That is the current system. So how do we get from early Harlem to the current system? How do we connect community to patient navigation for the whole healthcare system? The challenge was great. We found out that navigation has to include people who are not professional, and we call them patient navigators, along with people who are professionals, such as nurses and social workers, on one team. That's not natural in the healthcare system in America, nor is it natural anywhere else. So one of the critical things to do to develop patient navigation is to create a team of people that involve people who are non-professional, working closely together with people who are professional, like patient navigators working with nurses and social workers, concentrating on connecting the patient's journey to the point of resolution. So that's what's happened in America. And the question is, how could Latin America and other parts of the world, Asia, implement the patient navigation system? I think that the policymakers have to understand the real challenges that patients face in determining what the policies should be. Now, for an example, if a patient is uninsured, in America, the coverage is called Medicaid and Medicare for poor people. If a patient is uninsured, they don't have a way to get into the system at all. So policymakers have to create policies so that people have healthcare insurance or a way to get into the system at all. Policymakers have to understand that people that work in communities that are called patient navigators in communities don't have an easy way to work within the hospital system itself. So in Harlem, what we did was to create a system in which the community patient navigators were also brought into the healthcare system itself. This is unusual in healthcare, to bring people from the community who understand the problems of patients into the system itself. And the critical thing in Harlem that helped us to make navigation possible was the acceptance of the patient, of the patient navigator who had a community origin to work within the hospital system itself. And so, to me, one of the barriers that has to be solved by policymakers is to create a system where the patient navigator from the community is within the system. The issue is that community patient navigators stop at the door of the hospital. they need to be welcomed into the hospital and work along as one team with the nurses and the social workers and the doctors. So that's a policy issue. And the big change that took place in Harlem was when patient navigators were brought into the hospital itself. And I'll give an example. I had a breast clinic. I was in charge of it in Harlem. And I brought patient navigators who worked in the community to be in the room with me when I examined the patient and told the patient, you need to have a biopsy of the breast, an uninsured patient. The navigator who was witnessing my examination then would take the patient to another room and sit down with them, the patient navigator, sitting down with the patient and asking the key questions to the patient. Did you understand what the doctor said? Many times the patient did not understand. No, number 2 question, do you have health insurance? The answer may be no. Then the navigator has to find a way to get them covered so they can have the service at all. What other problems do you have? The patient would say, I'm afraid, I fear the hospital system. I don't trust the doctors. The navigator has to find a way to create trust in the patient. So this connection of the patient navigator, which had not been in connection with the hospital before, becomes a part of the hospital team working very closely with the doctor and the nurse and the social workers, but directly with the patient. This is the critical issue of how patient navigation became successful. And when we showed that we increased the 5-year survival of breast cancer in Harlem from 39% to 70% using 2 things, patient navigation combined with free screening for breast cancer, this created saving of many, many lives. So the policymakers need to be shown the way to create the policy. And so finally, I was able to argue to the Congress of the United States in person to say what had happened in Harlem. And this was embraced by the Congress of the United States so that the Patient Navigation Act was passed in 2005 by the United States Congress with no negative votes. This was a sensational change. This was what happened in America, and this is the type of thing that can happen elsewhere. And so the bottom line is to understand the value of doctors and nurses who are skilled, first of all, to understand that. But to also understand that ordinary people who are in communities don't necessarily have a way of getting into the healthcare system to have the treatment given. I come into Harlem as a surgeon knowing how to cut cancer out of Harlem and thinking that I can do that. I can't do it because of the problems that I face. So the issue for the policymaker is to understand the journey that the patient must take to get from where they live through a complex system and eliminating the barriers to movement, which are financial barriers, communication barriers, barriers of fear and distrust. And that is what I say to the policymakers. And the answer is a team of people. And I'd like to give an example again, as pictured here, in the mile relay example. I'll say it again. Picture a mile relay race. There are 4 runners that are carrying a baton. The baton is the patient, as you see in the diagram. It's one team. the four runners. The first runner runs as fast as he or she can and passes the baton, the patient, to the next runner. And then it goes on to the end of the race. And for the patient, the race isn't over until the fourth runner or navigator crosses the finish line. And that is what navigation is all about. Teamwork involving patient navigators, doctors, nurses, and social workers working on one team to assure the rapid movement of a patient to resolution. And that is the best example I can give to show policymakers what patient navigation really is. In order to have a successful patient navigation team, all the navigators have to be trained to be navigators. The non-clinical navigators have to be trained to understand the problems that the patient has in the community, such as lack of insurance. What do I do about that? How do I get a patient who is uninsured to have insurance coverage? In America, that's through Medicaid and Medicare. The patient navigator, who is the non-clinical, has to have the capacity and the sensitivity to speak to and learn what the problems are that are faced by the patient. For example, if there's a transportation issue, the navigator has to solve that. If there's an issue of fear and distrust, the navigation has to get the confidence of the patient not to be afraid of the hospital, to know the hospital is there, the people in the hospital are there to help them. Those are examples. So the barriers that patient faces have to be understood by the patient navigator, and that takes training. And the navigator has to be trained to understand the hospital system itself and connect to the people within the hospital, such as the nurses and the social workers. So the training of the navigator becomes a critical issue to solve the navigation problem. And thank you very much for the honor of speaking to you, to have a chance to talk to you at the second Patient Navigation Congress in Latin America. I believe the solution to many of healthcare problems is to navigate people through the system, and essential within the navigation solution are regular people who are the patient navigators. And I'm honored to be able to talk to you today. Thank you very much.
Buenos días a todos, buenas tardes, buenas noches, donde quiera que nos estén sintonizando. Mi nombre es Nancy Peña, soy directora y fundadora de Navegación de Pacientes Internacional y es un honor para mí estar acá. Solo quiero preguntar si el Dr. Freeman está conectado para que lo podamos ver. Good morning, Dr. Freeman, this is Nancy, can you hear me? Okay. Entonces, mientras se comunica el doctor, voy a darles la bienvenida. Pues para empezar, es un honor estar aquí con todos ustedes en Bogotá, en el segundo Congreso de Navegación de Pacientes en Latinoamérica 2025. Quiero iniciar extendiendo un saludo muy especial a las autoridades de salud y academias presentes, a nuestros colegas de la Pontificia Universidad Javeriana, a la Universidad del Istmo, y también la colaboración siempre especial de George Washington Cancer Center con la doctora Mandi Pratt-Chapman. Y a todas las instituciones que nos han apoyado y en especial a nuestros patrocinadores. También saludo con entusiasmo a quienes se han conectado virtualmente desde países de Latinoamérica y también lugares como Rumanía, Filipinas, Brasil y Estados Unidos, entre otros. Su presencia confirma que la navegación de pacientes es ya un movimiento global, con raíces fuertes en nuestra región. Nos unimos en este momento histórico, como decía la doctora Peña. Hace apenas unos años, hablar de navegación de pacientes parecía un concepto innovador reservado únicamente para países de altos ingresos, con sistemas de salud robustos y grandes presupuestos. Hoy, gracias a la evidencia científica y la experiencia práctica, sabemos que la navegación no es un lujo, sino una herramienta esencial para garantizar el acceso, la continuidad y la dignidad en la atención en la salud. Y lo más relevante, no se limita a la oncología. La navegación está impactando positivamente en áreas como diabetes, enfermedades cardiovasculares, VIH, salud materna, salud mental y tantas otras condiciones crónicas que representan enormes desafíos para nuestras comunidades. En Latinoamérica, la realidad es compleja. Sistemas fragmentados, distancias geográficas que separan a los pacientes de los servicios, barreras económicas, culturales y lingüísticas, y profundas desigualdades sociales. La navegación de pacientes surge como un puente que conecta al paciente con el sistema, al sistema con la comunidad y a la comunidad con la esperanza de un mejor acceso a la salud. Este congreso es una prueba de que nuestra región avanza. Cada país aquí representado trae consigo historias, aprendizajes y modelos que enriquecen la construcción de sistemas más humanos, adaptados y sostenibles. Desde Navegación de Pacientes Internacional, NPI, hemos asumido el compromiso de impulsar esta transformación, junto con, orgullosamente, Pontificia Universidad Javeriana y las universidades El Istmo y George Washington Cancer Center. Gracias a este esfuerzo conjunto, cientos de profesionales y voluntarios han recibido capacitación y otros cientos de navegadores que también tenemos acá presentes y de forma virtual se han capacitado y certificado con NPI, con el aval de las universidades ya mencionadas. Y lo más importante, cada certificado representa el apoyo a una docena de pacientes acompañados, familias orientadas y a una comunidad con mayor acceso a la salud. Este logro no es solo académico, es una garantía para los pacientes de que los navegadores están preparados con estándares internacionales, pero también con pertinencia cultural y lingüística. Algunos ejemplos: un paciente en Guatemala, una mujer indígena, que gracias a un navegador pudo recibir un diagnóstico temprano de cáncer de mama y acceder a tratamientos sin retrasos, a pesar de viajar 13 horas de su lugar hasta el hospital. En Colombia, un adulto mayor en cuidados paliativos que encontró en su navegador a alguien que le explicó con claridad sus opciones y acompañó tanto al paciente como a su familia en cada decisión. En Estados Unidos, una familia migrante que recibió información en su idioma, rompiendo la barrera del miedo y la desinformación y logrando acceso a terapias vitales. Estas historias nos recuerdan que la navegación de pacientes no es solo un concepto, sino vidas transformadas. Lo que celebramos hoy no es únicamente un congreso, estamos consolidando una red que cruza fronteras, comparte conocimientos y responde a una necesidad común: humanizar los sistemas de salud. La navegación es hoy un derecho emergente en nuestra región. Es el lenguaje de la equidad y de la empatía aplicada a la salud. Este encuentro también nos llama a pensar en el futuro, como bien decía el doctor Jorre Freeman y la doctora Peña y el doctor Rodríguez. ¿Cómo consideramos estándares compartidos para Latinoamérica? ¿Cómo integramos la navegación en políticas públicas de manera sostenible? ¿Cómo lograremos que cada hospital, cada clínica y cada comunidad cuente con un navegador preparado? Además, queremos agradecer profundamente a cada una de las instituciones que nos han apoyado, tanto académicas, ONGs, fundaciones, organizaciones y patrocinadores. Y también un agradecimiento especial a quienes han confiado en NPI y Pontificia Universidad Javeriana, como las otras organizaciones, como aliados estratégicos para fortalecer capacidades. Y sobre todo queremos reconocer a cada uno de ustedes, los navegadores de pacientes, su labor diaria, que a veces es silenciosa y muchas veces invisibilizada, pero que es la esencia de este movimiento. Ustedes son los que transforman datos en historias de vida, métricas en resultados humanos y teorías en prácticas concretas. Que este segundo Congreso de Navegación de Pacientes en Latinoamérica sea un espacio de aprendizaje, colaboración e inspiración. Que de aquí salgan compromisos, proyectos y alianzas que permitan seguir creciendo juntos. Bienvenidos a Bogotá, bienvenidos a este Congreso y bienvenidos a un futuro donde la navegación de pacientes deje de ser una alternativa y se consolide como una obligación ética, un derecho de los pacientes y una estrategia de salud pública. Muchas gracias. So vamos a ver si el doctor nos puede dar unas palabras para iniciar el Congreso. Vamos a ver si nos conectamos. Good morning, Dr. Freeman. Can you hear me?
I can hear you. Can you hear me?
Yes, we can hear you, Doctor. How are you doing today?
Yes.
Okay, Doctor. So we are so honored to have you here live. We already listened to you, watched your video. And Doctor, do you mind to open your camera, please, so we can see you here in the auditorium?
Let's see. Let's see.
Yes, I think in the bottom of the screen, you will see the camera near to the Microsoft icon. So we just need to push there if possible, but if not, it's okay, Doctor, thank you.
I'm unable to bring up the picture. I can hear you.
It's okay, Doctor, so it's okay, don't worry about it. So, well, first of all, we want to thank you for taking the time to talk to all our audience. And we are so excited and honored to have you here. And we just have one question for you, Doctor, since we talked before about how challenging it is in Latin America to involve Minister of Health to finally, engage patient navigation. Like you just mentioned, right, in the United States, the Congress passed the law for navigation. So the question we have for you is, what do you recommend for Latin America, then we have more challenges than the United States, to engage Minister of Health to pass laws of navigation?
Well, I've given a lot of thought to this over the years. And the best way I can answer this is to tell you what happened in Harlem, finally to get to the point where the government is paying patient navigators to do their work. This began with documenting that Harlem itself was an area of excess cancer mortality. There are ways to do that. They recorded statistics by the government itself to show what geographic areas and what areas patients are dying at a high rate. Now, we found then that Harlem, New York, had the highest cancer death rate of any other place in the state of New York at that time. So that's the first step. And then we documented who lived in Harlem, what were the characteristics of the people living in Harlem. For example, what was their income? What was their level of education? What was their culture? What was their ethnicity? How many were uninsured? As a second point. So now you know an area of excess mortality in which people of a certain type, uninsured people, poor people, live. And then the next step is to create a patient navigation teaching program, which I know you know a lot about as a teacher yourself. So we have to find a way to teach the people who are living in Harlem as citizens to be patient navigators, as I previously had described in the talk that we heard. So there has to be some organization of people who understand navigation to teach the people to be patient navigators. Now, when you bring the strength of the people in a community to help the people in their community, you have a huge strength. It's much stronger than government giving instructions to people. So now you have a teaching program, and you're teaching patient navigators to do their work. And after you do that, you begin to request funding for the work that you've done. Now, the early funding in Harlem came from the American Cancer Society, and later from the Ralph Lauren Center and other donors. And finally, just less than a year ago, the laws of America were changed. In other words, the Medicaid and Medicare laws were changed so that patient navigators are paid for their work. So it came a long way from a community where people were dying at a high rate, find out who they were, what were the circumstances, teaching them to be navigators themselves and joining them into a team within the hospital, including the nurses and the social workers and the doctors, but not making them a part of the system. And finally, explaining to the Congress or the Secretary of Health or whomever is in charge where you are, the value of this. And that is what I think should be done in all the countries in South America that are involved and elsewhere. In other words, it's not an easy job. It takes a lot of effort. It takes understanding.
Yes.
No more powerful force in America and elsewhere than people helping other people. And I was amazed to find that people love to help people. And so navigation could be a guiding force, even to show us how to be cooperative in other ways beyond medicine. So in summary, patient navigators are people from the community who work on a team with people within the hospital. And the goal is to teach people how to navigate a complex system across the healthcare continuum, which I will describe to you what I believe it is.
Okay.
People live in the community, so you have to go to people where they live.
Yeah. Thank you. Yeah.
People need to get into a facility for a diagnosis and treatment. You have to guide them through to the point of resolution. And finally, they're still alive and they still need support them through survivorship to the end of life. And that is what patient navigation is.
Okay. Well, thank you, Dr. Freeman. And yes, I know that, as you mentioned, right, it's not like an easy process, but since we have you as a mentor and also, we have so many literature, I think this is a great, tips for Latin America and for other countries to start thinking about how the process should be to achieve our goal. And we appreciate, again, your time. And since, just to wrap it up, again, thank you so much for everything. Thanks to you, we are here together today, Dr. Freeman. Thanks, this is your legacy. And we just being very honored to have you opening this second Patient Navigation Congress in Latin America. So thank you so much, and bienvenidos todos de nuevo, y con eso aperturamos el Congreso. Gracias.
Thank you. Thank you.
Les agradecemos a las personas que nos acompañaron en la mesa de instalación del Congreso. Los invitamos a tomar asiento. Y nuevamente la Facultad de Enfermería de la Pontificia Universidad Javeriana y Navegación de Pacientes Internacional les dan la bienvenida y les agradecen su presencia tanto remota como in situ en el segundo Congreso de Navegación de Pacientes en Latinoamérica. Queremos darle un saludo muy especial a las personas que nos acompañan en el auditorio y que vienen de otros países como México, Costa Rica, Brasil y Chile, y también a quienes están conectados desde otras latitudes. Tenemos personas conectadas desde Estados Unidos, Canadá, Chile, también Costa Rica, México, Guatemala, Honduras, Ecuador, Nicaragua, entre otros países. No quiero dejar a nadie por fuera. Desde acá les enviamos un saludo súper especial. Y en este momento damos, como lo mencionó Nancy, inicio a nuestra agenda oficial. En este momento vamos a iniciar con el primer conversatorio. Nos acompaña la licenciada Rachel Allende, quien moderará el conversatorio titulado Experiencias en Navegación de Pacientes en Estados Unidos y Factores para una Implementación Exitosa de Navegación de Pacientes. Nos acompañan de manera presencial la doctora Mandi Pratt-Chapman. Vamos, antes, bienvenida doctora, por favor, toman asiento. Voy a hacer la presentación de las personas que van a estar en el conversatorio. La doctora Mandi Pratt-Chapman, que es directora del programa de navegación de pacientes del George Washington Cancer Center, quien nos acompaña de manera presencial y le agradecemos estar en Colombia. Y la licenciada Jenna de San Jorge, gerente del programa Apoyo Global al Paciente de la Sociedad Americana de Cáncer de Estados Unidos, que va a estar de manera remota. Vamos a ver los invitamos a ver el video y continuamos con el conversatorio.
Porque nadie debería enfrentar el sistema de salud solo, nació una misión que hoy cruza fronteras. Navegación de Pacientes Internacional, NPI, capacita y conecta a quienes acompañan con empatía y compromiso. Desde 2017, hemos formado a más de 150 navegadores de pacientes en 11 países de América Latina. Más de 300 pacientes han sido acompañados durante su tratamiento, porque navegar es transformar. Nuestros estudiantes lo dicen mejor que nadie.
Mi experiencia fue única, siempre lo voy a decir, porque me ayudó a empoderarme yo primero y en realidad para poder enseñar y empoderar al paciente más que nada. Sí, cambió en mi forma de trabajar. La relación con ellos siempre es la misma. Hay pacientes de muchos años que ya no son seguidas, pero siguen teniendo el teléfono, entonces por otras circunstancias por ahí siguen mandando mensaje. O sea, la relación siempre sigue estando.
La experiencia fue muy gratificante, realmente, pues por mucho tiempo estaba buscando como esa posibilidad de certificarme en navegación. En el país pues no existe esta opción. Con la información que se me brindó en la certificación como navegador, pues pude aprovechar varios de esos conocimientos para poderlos implementar en mi área de trabajo. Entonces me parece que es muy positivo ese aprendizaje que se logró tener. Actualmente yo ejerzo la navegación, yo soy el líder de un equipo de navegadores en una clínica privada acá en Cali, en Colombia.
Y los pacientes lo confirman. Un navegador hace la diferencia.
Mi nombre es Gloria Monroy y tengo 47 años. Fui diagnosticada en mayo del año pasado con cáncer de mama. El recurso más importante que las navegadoras me dieron fue que inmediatamente el mismo día que yo vine me llevaron con la doctora Chacón, que es especialista en senos. Me han apoyado ahí en el hospital diciéndome dónde está la clínica con la doctora, dónde está el laboratorio, dónde está la sala de quimioterapia. Yo he platicado con gente aquí en el Hospital San Juan de Dios que ellos no tienen navegador y sí les ha costado más el proceso. Y yo que gracias a Dios estoy con ellas, se me ha facilitado el acceso y ellas me han ayudado bastante.
Hemos crecido junto a universidades, hospitales y organizaciones aliadas. Creamos un nuevo curso en línea. Participamos en conferencias internacionales, revisamos competencias globales desde países como Filipinas y formamos parte del nuevo curso de navegación en español del George Washington Cancer Center. En 2023, celebramos nuestro primer congreso en línea. En 2025, el encuentro será en Colombia. Llega el segundo Congreso de Navegación de Pacientes de Latinoamérica 2025, en alianza con la Pontificia Universidad Javeriana. Un espacio para compartir experiencias, fortalecer la formación y unir esfuerzos. ¿Eres parte del cambio? Únete al movimiento, inscríbete, participa, capacítate, navega con propósito. Te damos la bienvenida al segundo Congreso de Navegación de Pacientes de Latinoamérica 2025.
Bueno, invitamos a la licenciada Jenna de San Jorge, gerente de programa Apoyo Global al Paciente de la Sociedad Americana de Cáncer de Estados Unidos. Doctora, adelante, por favor, nos comparte su cámara y puede iniciar.
Hi, everyone. One moment, please. I thought, can you see my slides? Can everyone see my slides?
Sí, sí las vemos y le pedimos por favor que cuando pasamos la siguiente nos diga next.
Okay, perfect. I thought I was sharing. Okay, not a problem. So good morning, afternoon, and evening, everyone. It's a pleasure to be here today. Buen día a todos. I'm really excited to be presenting at this year's second MPI Congress, and I'm sorry I can't be there in person, but I am happy to join the online community. For those who don't know me, my name is Jenna de St. Jorre, and I am a program manager for global patient support at the American Cancer Society. I'm based in Washington, D.C. So today I'll be presenting on our ACS Beacon initiative, which is for global patient navigation programs. And I'll briefly highlight other ACS global initiatives that connect to patient navigation. Next slide, please. So our vision at ACS is to end cancer as we know it for everyone. And we do this through a three-pronged approach to improving the lives of cancer patients and families. And we do it through advocacy, research, and patient support. So as we know, cancer can affect anyone, but it doesn't affect everyone equally. So there are many barriers that can impact a person's ability to prevent and then detect, treat, and survive cancer. And these barriers are because of those deeply rooted, long-standing inequities that happen at all levels of society. And they do tend to require an intentional effort for equal cancer outcomes to happen. Next slide, please. While most of the work at ACS is focused on helping people living with cancer in the US, ACS also has a global mission. So we support individuals and organizations around the world to increase access to cancer prevention, care, and treatment to improve health outcomes and end cancer disparities. So we work in prevention and screening, patient support, and healthcare provider support. And our current work spans 80 countries. So today I'm presenting on behalf of the Global Patient Support Team. Our work is primarily focused on improving patient experience. We promote patient-centered care and driving its delivery through two key areas, patient navigation and then patient and caregiver education. So our team also ensures the delivery of patient-centered care through our organizational strengthening work to building up civil society organizations. And they play a vital role in ensuring the patient voice and patient experience are at the heart of care delivery. Next slide, please. So here's our global patient support team. And I just want to mention Andrei Shibisov will be presenting later today on patient navigation implementation strategies. And he'll be doing this alongside Dr. Yomna Sharif, who'll be sharing the experience of the Bahia Patient Navigation Program in Giza, Egypt. So look out for their presentation. I believe it's in 2 hours. Next slide, please. So at ACS, we're on a mission to promote and facilitate patient navigation adoption, and adoption around the world through 3 key efforts. We have the Beacon Initiative, which supports health institutions and cancer organizations in low and middle income countries to design and implement and then sustain cancer patient navigation programs. We then have the Spark Initiative, which builds on Beacon, and it supports this integration and expansion of patient navigation into national cancer care delivery systems. And we're currently doing this in 3 countries, in Indonesia, Kenya, and Nigeria. And then we have the Global Alliance for Cancer Patient Navigation, and this aims to convene global partners to identify, elevate and unify solutions for those common challenges to patient navigation, particularly around adoption, implementation, scalability, and the sustainability. Next slide. So the Beacon Initiative stands for Building Expertise, Advocacy, and Capacity for Oncology Navigation. It supports health institutions and cancer organizations in low and middle income countries around the world with a focus on addressing health disparities in cancer care. So it helps health institutions and cancer organizations design their cancer patient programs as well as implement them and then sustain them. And it supports this integration of patient navigation into that cancer control planning and the cancer care delivery. So Beacon is free to access and use the resources. We do have an application process. The online platform includes the Global Oncology Navigation Toolkit, which is a comprehensive resource, and it features hundreds of online learning modules and downloadable materials to support program development. We also have the Global Oncology Navigation Community of Practice, and this is a network for navigation practitioners who are members of Beacon to connect, share their experiences, and learn through virtual events and other collaborative opportunities. Next slide, please. So our journey in developing and implementing Beacon started 10 years ago. From 2015 to 2020, we supported studies in Kenya and Uganda, and these were to assess the needs of cancer patients to inform the development of patient navigation programs at 2 national referral hospitals. That was the Kenyatta National Hospital in Kenya, and then the Uganda Cancer Institute in Uganda. So our work in Kenya and Uganda has allowed us to test these different capacity development approaches and resources before we actually started using them at a wider audience. So in 2020 to 2021, we convened an advisory committee of global practitioners and experts in patient navigation to inform that design of the Beacon Toolkit. This including Nancy Peña, who's currently on the stage, as well as other early patient navigation implementers from around the world. So based on their recommendations, the development of the toolkit focused on the what and the how for patient navigation programming. And the how is really essential because it's not usually included in other patient navigation toolkits and resources. So that was a real focus for the toolkit. So from 2022 to 2023, we launched and evaluated a 15-month pilot of the newly developed Beacon Initiative. And we did this with 10 health institutions and cancer organizations from 8 countries. And the pilot included 1 health institution in Guatemala, whom Nancy also connected us with, and then 2 cancer organizations in Brazil, all who are still part of Beacon. And today I do want to recognize our Beacon member from Guatemala, the Hospital General San Juan de Dios, because they recently launched their patient navigation program on September. So please join me in congratulating the hospital, including Doctora Patricia Chacon and her colleagues, because I know she's currently in the auditorium. So felicidades, congratulations to you all. And then in 2023, we opened Beacon to the broader global community of patient navigation practitioners. And this community continues to grow as we add new features and we continue to network around patient navigation. So this year we launched the SPARK initiative, and that stands for Supporting Patient Navigation Adoption, Replication, and Knowledge Exchange. So Spark seeks to create an enabling environment for patient navigation by leveraging our Beacon resources so we can spark that patient navigation policy and practice changes, and particularly in a country. So there are two ways Spark does this. We do it by assisting national leaders to identify policy gaps and opportunities and advocate for those policy changes to then integrate patient navigation into that cancer care delivery system. And then also by supporting health institutions and cancer organizations to design and implement those effective, sustainable, and coordinated patient navigation programs. And those are based on those countries' cancer care structure, the needs of their populations, and the resources available. So Spark implementation is from 2025 to 2030. It's currently in Indonesia, Kenya, and Nigeria. As I mentioned, it's a country focus. We hope, however, in the future to use our learnings from leading this process in the 3 countries to support other countries to integrate patient navigation into their national cancer care system. So watch this space. Next slide, please. Okay, so the heart of Beacon is the Global Oncology Navigation Toolkit. It provides a range of training and technical assistance resources on navigation program design, the implementation, and then the sustainability or integration of these programs. So the toolkit prepares users to cultivate a team approach to design and implement patient navigation programs, to measure those outcomes and share progress, to anticipate any change and manage it, as well as to plan for sustainability. So in the toolkit itself, you'll find that we pose these key questions in consideration. We showcase user examples. The toolkit itself is self-guided and it's self-paced, and it provides this easy to adapt resources and practical guides. So the graphic on the left of this slide shows the 3 different phases of the toolkit, from laying the foundation from your program to designing and launching your program to implementing and strengthening it. So there are 3 sections within each phase, which go into depth to prepare health institutions and cancer organizations with relevant resources. So phase 1 introduces the fundamentals of patient navigation, and it supports users to identify how to address barriers to timely and quality cancer care. And it starts with this section 1, which is more theoretical and lays out the foundations of why patient navigation is important, particularly in eliminating access to treatment barriers and improving health equity. This phase also includes guidance and resources on conducting a needs assessment in your patient population and then creating a vision for your program. So phase 2 provides tools for designing the program. It's determining those staff needs, drafting SOPs, hiring and retaining staff, etc. And then phase 3 is about using data to learn from your program and adapt that data to changing patient needs and implementation environment. So it does support you in resource mobilization efforts to then sustain your program, and in supporting your team by using soft skills, to successfully manage people. So each section is broken into several activities with resources to download online and which you can also work through offline. Next slide, please. So the toolkit lives inside this online community platform, and here's where we can connect our members to one another. We share announcements and we provide links to past virtual event recordings. And next slide, please. And Beacon is essentially getting patient navigation going in lots of places around the world. Currently we have 45 member organizations that are participating in Beacon, and our community continues to grow. Next slide, please. So here we can see a breakdown by region. Our member organizations include both health institutions and cancer organizations from around the world. And I know some of you are already in the room, so hello and thank you for being part of Beacon. Next slide. And here are the member organizations based in America, in the Americas, that are currently part of Beacon or have been in the past. Next slide. So while the toolkit is developed in English, it can be translated, at least the online text, into other languages like Spanish or Portuguese. And you can simply do this by clicking the translation option in the Google settings, or it'll automatically appear for you. Next slide. So we continue to welcome health institutions, cancer organizations, and individuals to join Beacon. It's free to join through an approved application process. And you can learn more about Beacon through the link here in the middle of the page, which is our public page. And feel free to send that to any colleagues of yours. And if you have any questions or you would like to join the community, please reach out to us at acs.beacon@cancer.org. Next slide. So now, in addition to Beacon, I'd just like to briefly mention we have the Global Alliance for Cancer Patient Navigation, and this was launched this year to bring stakeholders in diverse global settings to frame and assess all the challenges in global patient navigation that no single organization can solve alone. So it does have 3 objectives, being convened stakeholders, creating that unified patient navigation framework, mainly around global definitions of patient navigation, common guiding principles, and then that's those successful implementation strategies. And finally, to expand that reach, quality, and sustainability of patient navigation through awareness and dissemination efforts. Next slide, please. So we currently have 9 organizational members from 6 countries in Latin America and the Caribbean that are part of the Alliance. And again, some of you might be here at the conference today, so hello to you. We invite organizations working in cancer care, health systems, research, and policy to join the Global Alliance for Cancer Patient Navigation. It's at no cost to join, so if you are interested, please reach out to us at acsglobal@cancer.org. Next slide, please. And finally, I'd like to mention a suite of resources that can be used by navigators during their interactions with patients. So the Equipped initiative enables health institutions and cancer organizations in low and middle income countries to train and equip staff to provide quality cancer education to newly diagnosed patients and their caregivers. So the Equipped initiative, it's an extension of what ACS's reach as a provider of accurate cancer information. It also includes the distribution of global cancer education materials for patients and navigation, and these are available in 6 languages. And then in addition, there's a training curricula in English for health educators that can be delivered in person and online. So these resources, they offer this people-centered and accurate and easy to follow cancer information, as well as communication skill building activities in the training resources that navigators can then apply during their interactions with patients. Next slide, please. So here we see the different resources that are offered through Equipped. First, on the left, we have the country-specific and global suites of ACS copyrighted cancer education materials. So these are in the form of a booklet for patients and caregivers, and then a flip chart for health workers. And these are currently in English, Spanish, Portuguese, French, Arabic, and Indonesian. We also have training resources to upskill health workers to use the booklet and flip chart while engaging with cancer patients. So these come in a form of an in-person instructor-led curriculum through PowerPoint presentation, and an online self-paced learning. So these resources are also free, and they're available to member organizations through an approval process for those organizations to access and use them within their respective entities. Next slide, please. So the text and images in this slide are from the booklet and the flip chart. So this shows how we use easy to understand language, as well as imagery, and to get that closer to meeting the, to get closer to meeting the needs of the populations that our partners or organizations are serving. So it's good for patients who might have less formal education, less resources, or they may be impacted by myths and stigma to seeking appropriate and timely care. Next slide, please. So up until now, we've been offering Equipped to our partners in Kenya, Uganda, Ethiopia, and Indonesia, and Brazil. But on December 11th, we'll be launching Equipped to the global community. So please do feel free to join the launch event to find out more about, what is this initiative, how it might benefit cancer patient education, how the initiative might support your patient education activities, and how you can get access to the resources. So we welcome any cancer organizations, health institutions, particularly from LMICs or other resource limited settings to join. So you can join, please send us an email at acs.equipped@cancer.org if you're interested in joining the launch. Next slide. So finally, I believe there's a fair or virtual mural that's available later today. So we will have some resources available there on Beacon, the Global Alliance, and Equipped if you'd like to learn more. So please do visit those. And then lastly, I'd just like to thank MPI and the Pontificia Universidad Javeriana for allowing us all to participate. And thank you to everyone for your time. And I look forward to the discussion.
Muchas gracias, licenciada Jenna. Le invitamos para que después de la conferencia de la doctora Mandi nos acompañe en el conversatorio. Y damos la bienvenida a la doctora Mandi Pratt-Chapman. Adelante, doctora. Sí, para poderle...
Buenos días. That's about all I know in Spanish. I apologize. I'm so pleased to be here today. I'm Dr. Mandi Pratt-Chapman from the George Washington University Cancer Center. I've worked a long time with MPI and with Nancy. And I'm going to share with you some research results from a study that I did a few years ago that where we were investigating how do you make successful patient navigation programs. So we heard from Dr. Freeman why we need patient navigation, and we heard from Jenna lots of resources on tools for implementing. And what I wanted to do in this study a few years ago was to talk to people who were in programs and find out what were the key ingredients that they needed to have a successful program. So our research question again was, what are the implementation factors that are important for a successful and sustainable patient navigation program? We interviewed 17 stakeholders from across the US, and these included navigators, their supervisors, and administrators. And we asked them a series of questions that were guided from what is called the EPIS framework, I don't have that memorized, exploration, preparation, implementation, sustainability. So we used that as a framework in order to guide our semi-structured interviews. And this is a breakdown of the participants in our interviews. You can see that there's a mix of individuals from across the US, mostly female, from broad regions in the U.S., well-distributed in terms of rural and urban, and mostly patient navigators, but also a fair number of administrators and supervisors. And this again is the EPIS framework that I mentioned. So we wanted to look at inner context factors, outer context factors, bridging factors that might facilitate patient navigation, as well as individual program innovation. So one of the first high-level themes that we found through our research was the demonstrated need for services. And this came in a number of different ways. Most of the rest of my slides are going to be a little wordy because they're quotations. So in this program, they said, based on previous research looking at minority, underserved, English as second language, because those are the people who benefit most from navigation, we've seen a decrease in time to diagnosis. We're looking at screening adherence, and then again at time to diagnosis or whether definitive resolution if it's not cancer. And I just want to point out here, Dr. Freeman also authored an article about principles of patient navigation, and this quotation really highlights a number of ways that you can put boundaries around your navigation program. So first, the population being served was identified. So this program identified who would benefit the most from these services. Second, they chose a time point. So they looked at screening adherence and time to treatment. So they really wanted to reduce the time, and that was their metric, was reducing time and maintaining adherence. So that's one way to show value, is to show through a change in, say, time or access. This other program showed value and demonstrated need for services by showing how there was a need for patient navigators to do financial navigation. And so rather than the patient receiving a large bill at the end of their cancer care treatment, the navigation program was really designed to help the patients understand what costs were coming up so they didn't have a big shock, and it wasn't devastating at the end of their care or throughout their care. Another way that a program showed demonstrated need for services, they had patients with a lot of late-stage disease, and this is also something that was true in Harlem when Dr. Freeman implemented his program. And so the goal of this program was to really downstage disease and reduce the number of late-stage diagnoses in their institution, and make sure that people were getting their cancer screening. So whereas one program was looking at screening adherence and time to diagnosis, this one was really trying to downstage the cancer for greater survival. So the second major theme that we identified in our study was external incentives, and these also looked like a variety of kinds of things. In this program participated in the oncology care model, and the oncology care model was a value-based model in the US that required patient navigation as a component of quality care. And so this program was able to reinforce their program and get additional resources for their program because of this external pressure of the payer. And the payer was saying, you need to have navigation services. By demonstrating those services, they were able to get paid, and then through that, they were able to reinvest in their program. Another external kind of factor or incentive is accreditation. So this other program mentioned that they were participating in the American College of Surgeons, cancer accreditation, and this is a very widely known and reputed accreditation in the United States for quality. And this program also requires patient navigation. It's varied a little bit over the years from a patient navigator to a patient navigation process, but the need for accreditation and maintained accreditation was a strong external incentive for the program to be successful and demonstrate why they were so critical to their institution. Another thing that's very common in really any kind of program implementation is leadership support. So internal leadership support for this program at the highest level enabled this program to be successful, since people were paying attention at the very high levels in terms of program implementation and success. Another key factor to success is role delineation and scope of practice. So navigators are coming in with community knowledge. There's a rich history of community health work, of nursing, of social work, and really identifying what is the role of the patient navigator and how do they complement and work with the team is critical. So at this institution, they mentioned that they go through and they find out, what is the best process for the navigator, how do they ensure team fit to optimize the success of the program. Right along with that is clear protocols for organizational context. So it looked like there were lots of great materials in the toolkit that Jenna mentioned, but having an idea of what you really want to accomplish and how that's going to work within your institution. In this case, they were very focused on emergency room visits and trying to prevent hospital admissions or additional emergency room repeats. And so what they did was if someone came into the emergency room, they would follow up and say, did you get what you need? How are your symptoms? And try to make sure that the patient was, the symptoms were managed and the patient knew what to do so that they could avoid another ER or emergency room visit. Another key theme, training support. So this is why MPI is so important. So making sure that you have training on the fundamentals of patient navigation, which I will talk about a little bit later today, but also the specifics of your particular context and what you need to do in practice as a navigator. And then I think a number of things that I've mentioned already speak to this, but just kind of very clearly the ability to demonstrate value is also a theme in our data in terms of navigation program success and sustainability. So in this example, showing positive impact to leadership was key to demonstrating value and showing the impact on patients. At this institution, I looked at patients who were navigated versus those who were not navigated and what those outcome differences were to demonstrate value. They also identified that by retaining patients in the system, that this was actually the most profitable program that they had ever evaluated. So that was a huge demonstration of value for sustainability of the program. And then funding stability is also closely related to that. So this navigator mentioned, if someone says, oh, this is really important, but then when the free money goes away, the program doesn't have support, that is an indicator that the program is likely not to be sustainable. So finding those internal champions, those clinician champions, physician champions, administrator champions, and how you're going to demonstrate success and establish that funding stability is really key. So this just shows you kind of where the themes that I talked about fall along the EPIS framework that I mentioned. And so there's in Spanish, and then for those of you who want English. And I also wanted to share with you this framework from the World Health Organization. I was part of the development of a technical paper through the World Health Organization where we looked at patient navigation, scalability in low middle income countries, and this was the stepwise process that they provided in terms of implementing a program which included knowing, engaging your stakeholders, again, finding those leaders, identifying your priority patients, identifying the scope of your program, implementing, piloting, and evaluating, and then continuing to refine. So I think this is a helpful and easy process to follow that I think aligns pretty well with what Jenna was talking about, as well as the materials that I can speak to later today. So overall, these are just the key takeaways. If you fell asleep while I was talking, this is your quick catch up. So what I would like you to remember and take away are get clear on your funding and your financial investment, like how are you going to support your program? How is your program going to be sustainable, and what supports the resources for your program? Identify your need. So what is it that your patients are experiencing? Where are the gaps? And where's the greatest need, whether it's a particular patient population or a particular part of the cancer continuum, or a particular aspect of the cancer care process. Identify where is the problem and how are you trying to fix it? What is the role of the navigator in that process? And then again, I mentioned this several times, but engaging key stakeholders, so finding your leaders, finding people that are going to champion your work internally. And I think, a really important piece that I hope that this helps inform is, while the navigator is a bridge for the patient to the institution, the navigator can't operate alone within the institution. So they really need these leaders and champions to help connect them within the institution so that they can facilitate that assistance to the patient. So this is really where you find your stakeholders. And then you also need external folks at community-based organizations where your resources are coming that you are going to navigate your patients to. As I mentioned previously, identifying kind of clear role delineation, scope of practice is really important so that people can operate optimally as a team. And then clear protocols that fit the organizational context that account for the capacity you have as an organization and the resources available. And you've heard this several times now, but training is important at various levels in terms of understanding the process of the cancer continuum, the process of your particular institution, and what the patient in particular is going through in that journey. And then finally, always, I always love getting feedback because I try to make things better. I always think 6 months ago, how did I not do this differently? So like making sure that you're evaluating your program, looking at your data, where can you improve and refine so that you can continue to have a really strong impact. And these are just the references that I mentioned throughout my presentation and my contact information. So thank you so much.
Muchas gracias, doctora Mandi. Entonces, damos inicio al conversatorio. Doctora Jenna, le pedimos al público que prepare sus preguntas. A las personas que están conectadas a través de Zoom, pueden colocar las preguntas en el chat y nosotros las transmitiremos a nuestras invitadas.
Thank you so much. I don't know if, all right. Jenna, can you hear me okay? Yeah? A little low? Can you hear me better? Okay.
That's a bit better, yeah. I was like, it's a little faint.
Okay, sorry, thank you. All right, thank you so much for your amazing presentation. We're just waiting to see if there's any questions in the audience and gather questions from the online participants. And so I'm not sure if there was anybody who had any questions here out in the audience. You could raise your, si puede levantar la mano si tiene preguntas ahí. Veo un señor, so it looks like somebody does have one. And thank you so much, Dr. Pratt-Chapman, for your presentation. That was excellent.
Good morning, excuse me, but I'll do it English. I prefer a question in Spanish, is possible, or
no, sí, pregunte nomás en español, señor, por favor. Sí.
Ay, muchas gracias.
Los intérpretes, no se preocupe.
Felicitaciones por bienvenida, doctora Mandi, doctora Peña, doctora Jenna, por estar en nuestro país y compartir este conocimiento y experiencia tan interesante sobre el tratamiento del cáncer y otras enfermedades crónicas. La pregunta es cortica. Teniendo en cuenta los avances que hizo Biden en la pasada administración, por ejemplo, el Moonshot Genius Act, ¿qué impacto ha tenido el One Beautiful Big promovido por Trump respecto al Medicare, el HCA, el Affordable Action para la población migrante en Estados Unidos para acceder al tratamiento del cáncer y otras enfermedades crónicas? Ese proyecto One Beautiful, ¿qué impacto ha tenido y qué tan concreto va a ser para la navegación y el acceso de la población migrante en Estados Unidos? Es única.
So I think that would be a good question for Jenna, if it's okay for Dr. Pratt-Chapman. Is that all right for Mandi to answer?
Yeah, I think that's more appropriate for Dr. Mandi.
Okay.
Yeah.
All right, thank you for the question. It's devastating, honestly. I mean, I think our nation is highly divided, and our research enterprise and our political system is not in sync right now. So the incredible leadership of Dr. Freeman and the incredible research that has laid the foundation for this innovation is definitely not aligned with what current administration and the limitations are doing to healthcare. I'll name just 3 major concerns. You mentioned migrants, so I think at every level there's concern about safety at a basic level right now. And I know we had a breast screening campaign. We have a lovely community partner that's been long in the community named Nueva Vida, and we scheduled 3 free mammogram events. And I'll call out my wonderful colleague, Claudia Campos, who was key to that and hopefully listening. And we had a number of women who didn't want to come and didn't come because they were afraid of being, facing ICE. So we did eventually get folks to come back and get their screening, and we successfully navigated everyone who had adverse findings, and at the end, nobody had a positive diagnosis of cancer, but it's a serious concern. So that is one major implication. I would say the second is, you also mentioned Medicaid. So if the Medicaid cuts of the bill that you mentioned do actually come to fruition, I have a very small sliver of hope that maybe if we vote different congressional leaders in 2026, maybe that will be prevented, since it was scheduled to really phase in 2026 after the elections, I think also for political reasons. And so if that does come into effect, a massive number of people will have loss of health coverage, and that will mean it's much harder for the navigator to do their job and much harder for patients. And the third area that I'll just mention is that we do have a major financial problem with sustaining our comprehensive care through the Affordable Care Act. And this massive change that the current administration has issued in also will affect rural areas even more than urban areas. So we are facing some pretty big cliffs, and I appreciate your astute insights into that challenge, and I hope that we'll be able to address that the best that we can. So that's what I got.
Thank you so much. Thank you so much, Mandi. It's incredibly challenging. I think knowing that patient navigators, one of, I feel like, the superpowers is to adapt and to find solutions, but also realizing that, the hope always is that the climate around, and then in terms of the political climate and policy, exactly, continues to support that. And very challenging when that's not what we're seeing. Yeah, thank you. I was wondering if there are other questions, otras preguntas acá de la audiencia acá, o en persona, o por Zoom.
Tenemos 3 preguntas. Pregunta Valeria Bernal Campos, que está conectada. Actualmente, ¿cuáles son los principales desafíos que existen en esta área?
En esta área de
navegación.
De navegación. Okay, so Jenna, I imagine that you heard that question as well translated.
Yeah, I did. I mean, there's so many barriers that we can discuss, and I think it's kind of difficult to hone down on them, because the crux of patient navigation is really to address any barriers, whether it's access, communication, so being able to understand the cancer, education that your new diagnosis, let's say, to cancer. It's also, your finances, as Dr. Mandi was saying, financial instability is really difficult for a patient. It's one of those key barriers and something that every country is kind of tackling in their own way when we have, maybe a national health insurance, but that doesn't cover cancer, comprehensive cancer treatment, or if we've got a private situation for healthcare that, again, isn't meeting those needs. So the key ones, I would say, is probably financial barriers in a way. I would say also being able to communicate really what treatment process a cancer patient needs, and then also being able to adapt those communications, being able to provide what the cancer patient needs, through that continuum of care. But like I said, there are so many barriers. I would never want to just focus on, some of those key ones. I mean, I would want to tackle as many as possible. But I'll hand it over to Dr. Mandi to chime in.
Sure. I'll just give you a current study that I'm leading with my colleague, Dr. Hannah Aram in Washington, D.C. We have systematized screening for social needs across 5 cancer centers, and we're providing navigation services kind of on the latter end of treatment after folks have received at least one modality of treatment. And I will tell you that in Washington, D.C., across these 5 hospitals, the 4 greatest barriers on the patient side that we've seen are paying for the basics, so financials, as Jenna mentioned, and all of these are related really to that, food insecurity, transportation, and housing. And unfortunately, because of some of the changes that have materialized this year, we have fewer resources in our community to address those barriers. So I guess I just wanted to jump on to say, the patient navigator isn't a magician, right? We really need, as Dr. Freeman mentioned, advocacy for policies that are supportive. And while in the US, some of our policies may not be going in a supportive direction, clearly the navigator can be more effective when there are community resources and policies that are able to facilitate addressing those patient needs. I'll also just say from an institutional perspective, historically, I think we've had some tension between navigators and other roles, which I think is why role delineation is so helpful in building that team and process. I think that's better than it used to be, but just being clear about who is doing what. And then funding sustainability. So while we do have the Medicare reimbursement, it's been difficult to implement so far. It's always hard to implement something in a complex system. So really figuring out those workflows and figuring out a rate that is appropriate for the navigation activities where we can really sustain the services. So just at the patient and institutional level, those are some things that we've encountered.
Tenemos otras preguntas del público, de las personas que están conectadas. Me voy a permitir leer 3 que son, pues serían las últimas por el tiempo. Esta pregunta es para la doctora Mandi y dice, en redes asistenciales con alta fragmentación y territorios diversos como los nuestros, zona sur de Chile, ¿qué indicadores sugieren ustedes para evaluar de manera objetiva si la navegación se está implementando bien y los equipos están logrando los resultados esperados?
Yeah, that's a great question. It's hard because I don't know your geopolitical context that well, but I think what Dr. Freeman mentioned in terms of really understanding what is your patient need and what does the data look like. So I don't know if you have comprehensive screening and comprehensive data available to diagnose whether people are getting screened. Having a quality registration program where you can see where the disparities exist, whether that's getting to screening or getting to treatment or getting through treatment, I would say let the data guide you. Where do you see the most loss in terms of life and quality of life, and build your program around the biggest need, and then continue to grow from there.
I was actually just curious too, Jenna, if there's something that maybe you could offer in terms of thinking about what Beacon provides and what your programs provide that might be helpful for participant who actually, the attendee who
Yeah, so I was mentioning the toolkit and how we have these 3 phases. So in that beginning phase, I think you made reference to this, Dr. Mandi and Dr. Harold as well, is that that need assessment is really important. So, you know, in the toolkit itself, we provide sort of guidance and resources on how you can do that needs assessment. The good thing is like, because there's so many of you from all different countries and different walks of life, you know, these resources then can be adapted to what you need to do in your cancer care setting. So just like Dr. Mandi was saying, it's like, you know, it's always hard to understand what you need to do to get to that evaluation stage. But the good thing about Beacon is that you can kind of tailor those resources to your setting. So I would start there. And then in terms of like other resources that would be available for you to kind of monitor and evaluate, then that takes you into that phase 3 of the toolkit and also provides, you know, some various things that you can do either through routine monitoring or, you know, doing more of an extensive like evaluation for your program.
Thank you both so much. I think we have, was it one more? ¿Una pregunta más?
Hay 2 muy importantes.
Hay 2 importantes, ok, vamos a hacerla rápido.
Vamos a tomarnos este tiempo para hacerlas porque pues esa también es la idea de este congreso.
Claro.
Hay una pregunta de Claudia Campos del George Washington Cancer Center para la doctora Mandi. Why is important to consider from the beginning how we will evaluate a navigation program, how we will ensure data accuracy, that you said right now, and how we will disseminate the results or present the results.
Yeah.
Kind of thing.
Yeah. So la doctora estaba preguntando si tiene sentido como con las 2 preguntas y hacer las 2 a la vez para ahorrar tiempo.
Sí, yo creo que sí.
Okay.
No, la otra es diferente.
La otra es muy diferente. Okay, otra más. Okay, yeah.
Thanks, Claudia. So I'm not sure what to add beyond what I mentioned previously, but we have some pretty rigorous data checking in our evaluation process to make sure that we're capturing the value of patient navigation. And then in terms of disseminating our results, we do publish in the literature for academics, but we also disseminate our findings through educational products. And I think you can also use policy briefs and social media, trying to reach people at various levels. So to try to be succinct, I'll leave it there.
Thank you. Jenna, is that something you could respond to as well? Were you able to hear the question?
I didn't hear it quite well, but is it about dissemination? So, disseminating your evaluation findings, is that correct?
Dissemination of results, yeah.
Yeah, so I would say, I agree with Dr. Mandi said, but also, I think what we're currently grappling with SPARC and the Global Alliance is like, what are those kind of forums that, yes, reach people globally, but then also thinking about your kind of grassroots change. And I think Dr. Harold made reference to that as well as like, or maybe that was a question by Nancy in terms of like policy changes and so forth. So I would look for the target. What is it that needs to change, and what is it that needs to make a more enabling environment for those needs that are really that you're trying to grapple with in turn, what questions you were trying to address during your evaluation. And I think that would help navigate where you want to disseminate your channels. Is it at the government level? Is it more of a global scene? So do that inventory before you start your dissemination.
Thank you so much.
Yeah.
Esta es una pregunta un poquito retadora. ¿Han considerado eventualmente aumentar el área de intervención de navegadores fuera del área oncológica, como en otras especialidades médicas, con patologías crónicas, como en reumatología, pacientes con diabetes, por esta alta prevalencia mundial y que ya no son de manejo de atención inicial, sino de especialidad por sus comorbilidades asociadas? ¿Desarrollarían alguna herramienta de apoyo tal como se desarrolló para oncología?
Yeah, there's actually been quite a bit of work in other areas. I just don't know a lot about it since I'm in the cancer space, but there certainly has been a lot of navigation in chronic disease areas. I was part of a study tailoring navigation for PrEP for cisgender women in the DC area for prevention of HIV. So there's a decent amount of navigation in the HIV space now. Definitely kidney area. I think that you're right in pointing out the important thing the question is pointing out is that the skills of the navigator broadly are very transferable to helping the patient through other processes, but an understanding of what that particular disease site and those pathways look like is really important to be effective.
Thank you so much. Jenna, is that something you could also respond to?
I would say, I don't think I have a proper response for that. I feel like Dr. Mandi's, in terms of her implementation, she'd be the better person to respond to it. Yeah.
Absolutely. Thank you. Thank you so much. Thank you both so much. I think these were amazing presentations, and just really appreciate the questions that the audience had as well. And I think we'll wrap up because I know we're a little bit over time, but thank you. Appreciate it.
And just to let the people know online, I'll respond to any questions through the chat as well.
Oh, absolutely. Thank you so much.
Yeah, of course.
Thank you.
Thank you.
Muchas gracias. Los invitamos a la estación de café y les pedimos ser muy puntuales. Los esperamos a las 10:10 para continuar con la presentación en la entrada del auditorio, por favor.
Mi nombre es Alexandra Núñez, soy presidenta de Unidos contra el Cáncer, una organización de pacientes que desarrolla el programa de navegación en el Hospital México en San José, Costa Rica. Para mí y para la organización que represento, esta certificación de NPI tiene un gran valor enorme, ¿verdad? Porque nos permite profesionalizar el acompañamiento que venimos dando a los pacientes, pero ahora de una manera más sistematizada, estructurada y con un respaldo de todo el aprendizaje académico que tuvimos en estos meses, ¿verdad? Aprendimos que la navegación no es improvisada. Necesitamos conocimientos, herramientas, indicadores y estrategias que nos permitan guiar mejor a cada paciente en su recorrido dentro del sistema de salud, que ya de por sí es complejo. Esto especialmente porque imagínense en medio de la incertidumbre que significa un diagnóstico de cáncer, contar con alguien capacitado que nos acompañe, que nos oriente, que nos ayude a pasar esas barreras, marca una gran diferencia en la experiencia del paciente y su familia, y lo digo como paciente que fui y que hubiera deseado contar con este tipo de apoyo. En el caso de nuestro programa de navegación en el Hospital México, esta certificación viene a fortalecer lo que hemos estado haciendo, asegurando que cada persona no se pierda en el camino, que tenga acceso oportuno y que se sienta acompañado. Quiero resaltar que en las clases aprendimos la importancia de contar con el apoyo de los equipos multidisciplinarios, y como navegadores nuestro trabajo debe ser vinculante con el hospital. No es un esfuerzo aislado, sino un acompañamiento estructurado que ayude a reducir esas barreras de acceso, esos tiempos de espera, y que los pacientes reciban una atención oportuna y humana, ¿verdad? Bueno, yo hoy celebro que ya no solo tenemos la voluntad, sino también la formación profesional que nos respalda y nos compromete a seguir creciendo para dar lo mejor a los pacientes. Y quiero aprovechar para agradecer a nuestros profesores, en especial a Nancy, que con tanta entrega lideró todo este proceso de aprendizaje, a mis compañeros, porque juntos hicimos esta certificación, una experiencia de aprendizaje compartido muy valioso. Me encantaba cuando compartíamos las experiencias. Y como dice el lema en Unidos contra el Cáncer, juntos transformamos el dolor en esperanza. Muchísimas gracias.